good morning, everyone. And I want to say first a thank to the organizers for asking me to visit this wonderful country. With several of the other faculty, we did 3 days of Sri Lanka and climbed up Sirigya and saw the beautiful caves and had a wonderful time. And I have moonstone earrings to take back with me to remember this trip. So we're going to start this morning about an approach to menopausal hormone therapy. Where are we in 2019? I have no conflicts. So we all know that menopause is the cessation of ovarian hormone production, and the average age of menopause is about 51. We term it premature menopause if it occurs before age 40. And perimenopause is something a lot of patients come to ask us about. Does it last 10 years, 5 years? The average time of the transition of ovarian cessation is about 6 months, up to 18 months, but it rarely is longer. I think the pendulum has swung back and forth from the 60s and 70s, where we put hormones in the water supply, to the times of the early 2000s, where no one got hormones, and now we know a little more and we have a more balanced view to treat symptomatic women. Benefits of hormone therapy that have been proven in randomized prospective double-blind placebo-controlled studies include the vasomotor flushes, the symptoms of vaginal atrophy. We know the distal third of the urethra of the bladder has estrogen receptor alpha and beta receptors on it, and that often women are misdiagnosed with urinary tract infections in the perimenopausal transition when it's a sign of estrogen deficiency. The effects of mood we'll mention. Osteoporosis, yes, and it's not going to be a focus of this talk. Estrogens prevent and treat osteoporosis. But before the Women's Health Initiative, there were questions about cardiovascular disease, and we still have issues related to cognition. Now, the whole issue is why back in the late 70s and early 80s, we were telling women to take hormone therapy at menopause. There was estrogen data, both in basic science and in clinical studies, that made sense that estrogen should be good to the female vascular system. There was epidemiologic data that showed a decrease in coronary heart disease in retrospective, prospective, or case control studies. And there was a lot of biologic plausibility because estrogens decrease your bad cholesterol, LDL, and Lp(a). They decrease blood pressure, at least acutely, at physiologic doses. They decrease fibrinogen, improve vascular reactivity in a normal vessel wall, and decrease adhesion factors and work as an antioxidant. But after the WHI came out, there was a question, was all that presumed biological science really wrong and related to a healthy user effect, i.e. the women who got prescribed estrogens were healthy and we thought the estrogens were helping, but maybe it was other aspects of their lifestyle. So as you remember, and again, there's almost been a generation since of pipeline of physicians and endocrinologists since the WHI. And I don't know if in Sri Lanka the same exists, but for sure in the US and Europe, people like me who grew up learning about estrogens and prescribing it versus my trainees who have not been taught, there's a new need to train more people in how to use hormone therapy. Just to remind you, a couple of points about the Women's Health Initiative. It was a double-blind, placebo-controlled study. It was in the US. It involved using conjugated estrogen, Premarin, and daily medroxyprogesterone, or placebo, if the woman didn't have a uterus. There were 16,000 women with an intact uterus, and their mean age was 63. They were starting hormone therapy 13 years after most women would have started hormone therapy. The average age of follow-up was 5.2 years. They couldn't be symptomatic, which is why we treat women. So it's a different cohort, and you need to think about that. Some had been prescribed estrogen, very few were on it and stopped, but the majority of those women in the WHI had never seen hormones for those 13 years. And here you see their age range. The results of the WHI initially were stopped. It was stopped abruptly because of side effects of a relative risk increase of about 26% in breast cancer, coronary heart disease, stroke, pulmonary embolism, but a protective effect on colon cancer or hip fracture. Now, after the WHI, the issues came, why did this study totally contradict everything that we thought we knew about how estrogens worked at different target tissues? One was the age at time of diagnosis and treatment. Again, we never treated women in our clinics back then at 63 to start hormones. We started it at the time of menopause. The dose of estrogen in older women. The role of increased BMI. 2/3 of this cohort had a BMI over 25, and a third had a BMI over 30. Next, the role of the type of progestin. Was there something about medroxyprogesterone that was less, or had more negative effects on either the breast or the cardiovascular system versus natural progestin? Next, the impact of daily versus intermittent progestin. The body doesn't make progesterone daily, and was there something about giving that daily progestin, which is a growth factor in the breast, that impacted breast cancer? High unblinding rate. But at the end of the day, although the press releases around the world said, boy, be careful of using hormone therapy, the absolute risk in this cohort of people who were recruited were not the kind of patients that we would normally treat, was about 1 event per 100 women treated for 5 years. So after the WHI came out, we started thinking about primary versus secondary prevention. The design of this study was very much patterned after the cholesterol studies, where people were shown to have secondary prevention and then they went to primary prevention. But lipids don't work like hormones, and we'll come back to why that's not true. And it raised the issue of, is it better to use hormones if you're going to use them as primary prevention, and that there may be an increased risk if you use them later when vascular disease or early breast cancer is already on board. The second arm of the study came out in 2004 and had many less press releases about it. It was in almost 11,000 women, same age range, given placebo or conjugated estrogen for almost 7 years. And in this study, there was no increased risk of cardiovascular disease. There was this increased risk of stroke or pulmonary embolism, DVT, or pulmonary embolism. I think one of the biggest take-homes of the WHI was a take-home for us as clinicians, that if women are on estrogen and are hospitalized, they're at higher risk for blood clots. And so in women who are planned to have a surgical procedure, we should probably hold the estrogen in the perioperative time period. And suddenly, the breast cancer risk was not significant. In fact, it almost looked protective. And that was very shocking to people. So if you only were giving the estrogen and not with the progestin, you lost the breast cancer risk, you lost most of the cardiovascular risk, but you still had this hypercoagulable risk. You lost the protective effect in colon cancer, but you kept the protective effect on the bone. So it's been a long time since those studies, and the studies have been reanalyzed, and they've had longer-term follow-up. And if you look at it during the intervention phase and then all the risk ratios, they've sort of changed over time in the analysis. If you look at the combined study, if we look, the stroke and the pulmonary embolism and the DVT are still there. With estrogen alone, they're still there. So I think we can take home the point that women in menopause, at least when they're given it 13 years after they started menopause abruptly, have a small but statistical increase at risk of a hypercoagulability event. And we'll come back to that. Now, investigators in the laboratory wanted to say, why is this data so different than everything we predicted from prior science? So they went to the monkey model, and they took monkeys who are the closest to humans, and they fed them a healthy diet first, overectomized them, put them into menopause, and either then switched them to the atherogenic diet that we all eat, with or without conjugated estrogen. And the monkeys given estrogen had a decrease of 70% in their coronary plaque. The other group of animals, they fed the atherogenic diet their whole life, like all of our kids and our young adults. And then at menopause or ovariectomy, gave them estrogens, and they lost a lot of the protective effect. Estrogen is not, a gold pill that can prevent all cardiovascular disease. But most importantly in this model, animals fed a healthy diet, overectomized, then switched to an atherogenic diet without estrogen, and waited a period of time, which would be about 5 years in human terms, and then given the estrogen, no effect. So these kind of data supported the idea that if we're going to use hormones for symptomatic women at the time of menopause, we need to do it at the time of menopause and not treat women 15 years after the menopause to start, because the things are different in these two periods of time. What other data did we get from the WHI? Well, lipid profiles. So lipid profiles predicted a response to hormone therapy. They looked at a subset of patients who in the WHI and 700 controls, and if you went in and your lipids were treated, or you had good lipids, it predicted an improved cardiovascular response to either combined hormone therapy or estrogen. And why would that be? Well, the basic scientists went into the lab and started looking. What is the role of lipids and sex steroids on the vascular wall? Well, estrogen in a normal vessel wall is a vasodilator. It activates nitric oxide. It activates, and however, in an older vessel wall or one where there's already plaque, it activates macrophages and smooth muscle metalloproteinases, and it destabilizes plaque. So you don't want to start estrogen in a woman who already has vascular disease. Importantly, the coronary calcification score was lower in women on hormone therapy, even in this subset, especially a score for less than 100, and it was actually a relative risk reduction of about 50% if they were compliant. So again, these kind of data suggested primary prevention with hormones is safe for the cardiovascular system. And then here's the latest analysis on WHI based on age and time from menopause. As I mentioned, the WHI did not recruit symptomatic women, who are the women we normally treat now. However, if they did the subgroup analysis based on age, or importantly, time since menopause, if you were recruited and you were less than 10 years from the time of menopause, you had a protective effect in either arm. However, if you were suddenly given estrogens at a full dose, or maybe higher than what we would now consider a full dose, if you were 10 to 19 years or over 20 years, you saw the increased relative risk. So this again supported the issue that hormone therapy should be used as a primary prevention, but not a secondary prevention for vascular disease. Now, there's been 2 additional studies, neither of which are large or powered to really look at outcomes, including the KEEPS study and the ELITE study. KEEPS was over 700 women. They were given a lower dose of conjugated estrogen. I think this thing might be dying on the top line, 0.45. And the issue was, maybe if we bypass the oral route, we'll have a better effect. And so they used transdermal estrogen, 0.05, with cyclic micronizable progestin, more in a physiologic dose and without the medroxyprogesterone. Early intervention, however, it was not powered to look at outcomes, but most as a surrogate marker, carotid thickening, and there was no significant effect. There was no increase, but there was no decrease in coronary disease in the group, and a sub-study looked at cognition and mood and hadn't found no effect. They did find an improved sexual function in women now treated at the time of menopause with the transdermal, but not with the oral, which is somewhat surprising. Improved depression and anxiety with the oral, but not the transdermal. The ELITE study was similar powered, and it was and they actually found a better intimal thickening with oral within 6 years of menopause versus women who are recruited greater than 10 with a dose of 1 milligram a day. They found no effects of the coronary calcium scores, but as I mentioned, the WHI found an effect. So although those 2 studies were postulated to help us as clinicians figure out who and when to treat, they really didn't do a lot. And I think the analysis of the WHI is the most significant. So let's look at some other reasons we might consider either to start or to keep women on hormone therapy at the menopause. First, we talked about individual symptoms, the vasomotor flushes, quality of life, the vaginal atrophy, mood, and cognition. What do we know about estrogen's effects on mood? Well, in the perimenopause, the lifetime risk of a mood disorder is 10 to 23%, and it increases by 2 to 14 times at menopause. The risks are multiple, and the data, unfortunately, are not great quality about who is at highest risk. There's biological sensitivity, the effect of hormones. We know that when women are estrogen deficient and have vasomotor symptoms, their REM sleep is disrupted, they can be more fatigued, they have irritability. How does that sleep disruption affect on mood? There are psychosocial factors, past history of a mood disorder, attitudes about menopause, and loss of ability to conceive, life events, coping styles, social support, socioeconomic status, and education. Important, lifestyle, smoking, no exercise, and an increased BMI increase the risk of mood disorders in the perimenopause and menopause. These are the data from a large study, the study of women across natural menopause that was done with multiple ethnicities in the US and shows about the relative odds ratio for depression. And so you see that it's on the first panel, it's not going, slight increased risk as women progress through menopause. Different ethnic groups have higher risk of depression through the menopausal transition. But having different upsetting life events increases your risk. And of course, vasomotor symptoms. On the other hand, high social support decreases that risk. But estrogen receptors are on all your neurotransmitter neurons. So it's not that estrogen would treat depression, but estrogen replacement may improve response to neurotransmitter drugs, such as SSRIs or SNRIs. Now, what about hot flashes? We've known that hot flashes exist. We know that women who are estrogen deficient have hot flashes and that they are often bothersome and some kind can be really life disrupting, but we still don't understand what causes hot flashes. There's been a lot of work about the role of serotonin and the serotonin receptors. So weird that that doesn't show against the white. On the risk of hot flashes, but at the present, we don't know. A lot of people have looked into whether there's alternatives to treatment for hot flashes by soys. And here's an older meta-analysis that showed a moderate effect. It used to be that we said that we probably couldn't make a difference because you had to eat 2.2 kilograms of soy a day to treat hot flashes, which is a large amount. But now that soy products are powder, et cetera, women can use soy products to try to treat hot flashes. But remember that soy contains estrogenic compounds, so they're not recommended for women who've had breast cancer. Now, what about alternatives? The SSRIs and the SNRIs have been shown in meta-analysis to have a modest effect, probably half the effect of estrogen on hot flashes, as well as use of gabapentin and other drugs. What's in the research line? Well, there's people are looking at using low doses of DHEA, which is a prohormone that's converted into androgens and into estrogens. And of course, oral, I can never say this word, it's a serum oxymethylene, has been approved for dyspareunia, but not for hot flashes. Under study, the Rloxifene. And what's interesting and coming down the pike is the study of what might be influencing hot flashes by the basic scientists, that neurokinin B, or the tachykinin system in the brain, may be controlling GnRH pulse generator and response that causes hot flashes. So what they're looking at are neurokinin B inhibitors and whether they would modulate hot flashes with severe symptoms. So keep tuned for that. There have been some studies on stellate ganglion blockade, and vaginal testosterone has not been shown to be significant for hot flashes. The next question is, what about cognition? Well, historically, we had data of secondary intervention studies with hormone therapy, and those were given with either 0.625 or 1.25 of conjugated estrogen, and showed once you had Alzheimer's, estrogen therapy did not help, right? It didn't help. And again, that's secondary prevention. There was this study called the Cache County Cohort, prospective study in over 1,400 men and women, and they looked at the risk of Alzheimer's in the women who had been given hormone therapy. It wasn't a prospective study, and they looked for 3 years. So prior hormone therapy decreased their risk by 40%. The benefit of hormone therapy, however, started at menopause, and if you gave it for 10 years. Again, raising the issue of primary versus secondary prevention. Now, in the WHI study, there was a lot of press around the fact when they did their cognition study, it actually said that estrogen made cognition worse. However, if you look at their data, they looked at about 4,500 women aged over 65, and their outcomes were dementia and mild cognitive impairment. And they had an adverse risk ratio of over 2, but it turned out that when they re-adjudicated the data, this was not Alzheimer's. This was vascular dementia. So that fits into this same story of if you give women who are 13 years post-menopause hormone therapy at a big dose and you already have established plaque, you're going to worsen the neurocognitive effects related to the estrogen. And there was no effect on mild cognitive impairment, but the way they did the outcome was times 0, and then they went 4.5 years or 4.2 years later and had poor outcome measures. Do you all remember what you were doing 4.5 years later? Ago? So again, all these studies support this issue of primary versus secondary prevention. There's some new exciting genetic data about the timing of menopause, because we really don't understand why different families have different times of menopause. People are looking at the genes obviously involved in estrogen signaling, DNA mismatch repairs for those with premature ovarian insufficiency. We'll talk about that in another lecture. Immune function and some pathway analysis. But yet only 2.5 to 4% of the variation in when women go through menopause is understood. Okay. What about the risk of hormone therapy? We've known forever that women have more gallstones than men. It's related to estrogen. And so there's a small increased risk of gallstones. The DVT issue I told you about, maybe in the future we'll have a panel as women go through menopause for different genetic predispositions to blood clotting. And those women either won't get estrogen or get transdermal estrogen. Endometrial cancer, no, if it's given with at least 12 days of medroxyprogesterone or continuous progesterone. Breast cancer is the big issue, and the data from the WHI support that if a woman decides to take continuous progesterone, at least medroxyprogesterone, it increases the breast cancer risk slightly. So, what about breast cancer? The lifetime risk of breast cancer for women is 1 in 8 to 1 in 9. The meta-analysis of prior hormone use suggests no increased risk with physiologic doses short term. Long-term use, greater than 5 years, or family history increases the risk. It is true that women with breast cancer after hormone therapy have less aggressive lesions, decreased mortality, but again, that may be biased because they're getting monitored. The risk in the WHI was significant, but the absolute risk is quite low, especially if you look at the women who were treated in the years 50 to 59, and decreased risk with lower progestin exposure. So here's the most recent analysis from Joanne Manson's work in JAMA that showed, again, the breast cancer risk with estrogen alone was actually negative, with estrogen and progestin is slightly positive. Now, the most important study that just came out about hormone therapy was this one, again by Manson and colleagues in JAMA this past 2 years ago. And again, it's not important to see all the details, but look at those triangles on the right. And what you see is if you look at the top cohort, the women 50 to 59, all those triangles are to the left. That means taking estrogen was pretty good. As you increase the age, you see those triangles start to scoot to the right, showing increased risk. But there was no increase in all-cause mortality in long-term follow-up of the WHI, which is reassuring. Now, finally, a couple of comments about alternatives. First, testosterone. I ran the guidelines for the Endocrine Society on the role of testosterone in women, and there's going to be a new guideline, an international guideline that Sue Davis has run that will be published this September, so stay tuned. But there's really no evidence that we can find scientifically of an androgen deficiency syndrome in women. The data shows that testosterone patch at high physiologic dosing was effective in treating a subset of sexual dysfunction called HSDD, one more satisfying sexual relations per month, but it was denied at the US FDA because of concerns on breast and cardiovascular disease. But the initial guidelines and the follow-up guidelines said that we could consider using low-dose testosterone in selected patients for 3 to 6 months, watch for side effects, and monitor for overuse or signs of hyperandrogenism. The problem is that there's no FDA or approved use of physiologic testosterone preparations, and so people are using them off-label. And the long-term risk-benefit is unknown. Remember that a lot of sexual function in women is estrogen dependent. And then a final word about some other alternatives and potential risks. There's studies on the selective estrogen receptor modulators. Rloxifene is appropriate for early bone protection. It was equivocal for cardiovascular disease, and it worsens hot flashes. So it's really had limited use. Soy, little effects, maybe risk with some powders with high concentration. Herbals have been beneficial in controlled studies to date. There are many drug-drug interactions, and I'm sure in your countries as well as in our countries, people are going to alternatives all the time, and we're seeing side effects from alternatives because we just haven't studied them. So we often will stop things and then add them back and look for markers. The Endocrine Society and many societies are arguing against compounded preparations because of the lack of quality control of the delivery. I often use lipids and biomarkers to assess supplements patients are taking. And lastly, a little bit more about these bioidentical hormones. In the US, the top 3 are the ones that are given. They've been poorly studied, and it's unclear that they have any benefit. What's really scary to me and to our FDA and to the Endocrine Society is a new push, at least in the US, and I don't know if you're seeing it here, to give women estrogen and testosterone pellets at pharmacological levels, and we're seeing some major side effects, and it's a mass moneymaker in the US for anti-aging. Scary. We have FDA and other approved bioidentical hormones to give estradiol as a patch or a gel, and we have prometrium, natural progestin if people don't want to take medroxyprogesterone. So, we're a year later. I didn't change this slide. Short-term menopausal hormone should be considered for women who have symptoms. Benefits outweigh the risks, but we individualize the regimen and we use the lowest dose possible. Long-term, we have to weigh the benefits and risks for the individual patient. We're using lower doses, we're using transdermal delivery, we're using intermittent or no progestins if there's not a uterus. Alternative therapies, be careful. Do no harm. We need additional research. And it's only one part of how women are aging at the time of menopause. Estrogen shouldn't be put in the water supply, but it shouldn't be restricted. And with that, I'll stop and thank you.